Do we use the term reversible and irreversible for pressure onset?
The term irreversible?
Mm-hmm. Do we use it for stage 3 and 4?
No. It's all about healing. Okay.
So it still can heal if the patients
yes,
have stage 3 and 4.
Even a stage 4 pressure ulcer can still heal. Okay. And there are many approaches, either by granulation tissue or what we call as an autologous, meaning there can be a transfer of a part of the skin of the patient's body, and it will be grafted on the pressure sore. Okay, that's what we call a skin grafting. That's another approach. Okay? So delayed secondary intention, again, that is the secondary, that's a delayed also process. Okay, so we leave it open, heal it by granulation and by contraction of the wound, and then epithelialization. Okay, that's pretty much that's what occurs. Why is it delayed? Because we would allow it for the granulation tissues to develop first, and then we would allow the wound to contract. Okay, and then eventually it will re-epithelialize. That would close the wound. Okay. So that's the conservative approach. If you want to have a more dramatic approach, then you can go into skin grafting. The doctors might do a skin graft on those big wounds and cover it up, okay, with your own tissue. Okay, it could be from a pig skin, or it could be an autologous source, meaning the source is from the person, the patient himself or herself. All right. So we have these risk factors. If you have an advanced age, if you are anemic, if you have contractures, if you have diabetes, okay, the elevated body temperature, friction, immobility, obesity, pain, vascular diseases, these are all can affect, okay, risk factors for pressure injuries. This can contribute to the development of a pressure-related injury. All right, so we have this already. There's definition about the use of the proper term, okay? So only pressure-related injury is to be staged, okay? And remember, we have now 2 added, so we have a 6-category staging system. Can we name them? Can you guys remember it? What are the 6-category staging system for pressure-related injury? Let me start. Stage 1 is number 1. What follows it? After stage 1, what comes next?
Stage 2.
Stage 2.
Stage 3. Then stage 4. And then 5.
No, there's no such thing as 5.
Well, what are the last 2 again?
SDTI, the suspected deep tissue.
SDTI.
SDTI.
And the number 6 would be the unstageable. All right. So let's be very clear on that one, okay? Oops.
Okay, so 5 and
let me mute myself. Sorry about that. Okay. So we have the definition already. So we're good in that one. All right. Okay. So we have stage 1, localized area of the skin, intact with non-blanchable redness, just to summarize what we discussed. Stage 2, there is a partial thickness loss of dermis. Now, this is a new term again for you to learn. Okay. What's the difference between a partial thickness and a full thickness skin loss? Okay. When you talk about the word partial thickness loss, that means the break on the skin would be towards the dermis and the epidermis only. Okay, if you go beyond the level of the epidermis, okay, the dermis, okay, that means it's going to be a full thickness loss. All right, that would enter into what we call as a stage 3. Okay, so stage 1, it could be intact skin. Stage 2, partial thickness, meaning the layers involved would be your dermis and your epidermis. If it goes beyond these 2 layers, that becomes stage 3, and it's considered as a full thickness tissue loss. Okay, stage 4 is also considered as a full thickness tissue loss because it breaks the first 2 layers. Okay, but here we have the bone, tendon, or muscle in stage 4. Okay, here we have the subcutaneous layer involved in stage 3. Okay, so sometimes it can be visible that bones, tendons, and muscles are not exposed in this stage. Okay, that's the major distinction between the two. Right. So we have a major distinction between these two, and we have a major distinction between these two. All right. Okay, unstageable. Now there is a full thickness tissue loss, meaning it has gone beyond the dermis epidermis layer. Okay, a wound base covered by a slough or an eschar. Okay, that's another term that you need to know. What is a slough and what is an eschar? Okay, in the wound bed that will eventually usually be tan, brown, or black. Okay, so for as long as it extends only towards the first 2 layers of the skin, the epidermis or the dermis, that is considered as a partial thickness. Okay, if it goes beyond those 2 layers, that becomes a full thickness wound. All right, so that's a good way if you're documenting your wound and describing it. You can use those terms. A full thickness wound, meaning everybody knows that when you say full thickness wound, it has gone beyond the dermis and the epidermis. Okay. And then we have the 6th stage, which is the suspected deep tissue injury. Okay. When it appears as a localized purple or maroon area of discolored intact skin again. Intact skin here, the only differentiating factor here would be really the color. Okay. Purplish or deep maroon, deep red, okay, or blood-filled blister. Okay. All right, let's look at some picture. Partial thickness, full thickness, okay. So pretty much here, superficial, partial thickness, full thickness, depending on how many layers of the skin are involved again.
Oh God, oh God, oh God.
All right. And again, if you're confused with this term, which one is the upper layer, dermis or the epidermis, the word epi means on top. Okay, so the word epi means on top. So that means on top of the dermis. That way you won't be confused. All right. The word epi is on top. Epidermis on top of the dermis. That will always be your outermost layer. All right.
I have a question, sorry.
Yep, go for it.
For the unstageable, so it's basically it's stage 3 and 4. What is the injury be covered by slash or
you won't even call it as a stage 3 or 4 because you don't know how deep the involvement would be. So that's why we call it as unstageable, unclassified. Okay.
We don't know how deep it is, but it's still a full thickness.
Yeah, pretty much it's still deep. But we cannot call it as a stage 3 or stage 4 unless you remove the slough and the eschar. And I will show you pictures so you can appreciate it better. Okay? But usually, okay, let's say the doctor decided to debride it. Okay, so the doctor did a surgical debridement, removed the slough and the eschar. Now the wound is exposed. Now you can stage that whether it's a stage 3 or 4. Okay. That's the only time that you will stage it. For as long as it's not exposed and still covered by slough and eschar, we call it as unstageable because we don't know the exact depth. We cannot measure it. Okay.
Yeah.
All right. Collaboration again in terms of the skincare. Okay. So do not delegate what you can eat, right? Although assessment for the presence of skin impairment is a nursing responsibility and is not to be delegated to an unlicensed assisted personnel, okay, the UAP can still provide hygienic care in most settings, okay? That means you can still delegate the cleaning of the private area of these patients if it's in the coccyx area, if the patient becomes incontinent, okay? So an important instruction, okay, for your CNAs once you get your licenses, report any changes in the patient's skin conditions such as redness, irritation, dryness, maceration, or discomfort. All right. Provide care to prevent the patient from exposure to body fluids, okay, such as urine, feces, wound drainage, and gastric secretions. Observe bony prominences. That's an important instruction for them. Okay, always inspect the areas where there are bony prominences: the sacrum, the scapula, the ears, the elbows, the heels, the inner and outer malleoli, the inner and outer knees of the patient. Okay. Observe and prevent any areas of pressure from external devices such as oxygen tubing, nasogastric tubing, because this can cause a pressure-related injury as well in the long run. Okay. Casts, braces, urinary catheter tubing, or the drainage tubing. These are all factors that can also contribute to a pressure-related injury in the long term. Okay. Provide perineal care as needed and observe the area for any signs of skin breakdown. These are the things that you can instruct your UAP when you're delegating certain tests. Okay. So again, quick review. Okay, stage 1, stage 2, stage 3, and 4. All right. Okay, let's go a little deeper now. Okay, stage 1. This is a typical picture. This is what you might see. Okay. Some of you might consider that as, oh yeah, maybe the patient was irritated from the urine or feces. Now, how would you differentiate this if this is an irritation caused by fecal materials or an extended exposure to urine? How would you differentiate it from a stage 1?
And I'll have her give you an answer.
I'm sorry, say that again, please, Paulo.
We can do the Blanche test.
Yes, Blanche test. Okay. So intact skin, non-blanchable redness, suspect a stage 1 pressure-related injury. Okay, and usually it's in a localized area. So in this case, it's in the sacral area of the patient. Okay, so darkly pigmented or dark-skinned individuals, okay, may not have visible blanching. Okay, so it can be some changes like grayish changes in their skin color. Okay, but what other things can you include in your assessment? If the patient complains of pain, okay, feel the area, okay, is it boggy, is it firm, is it warmer, okay, warmer compared to maybe the surrounding area here, okay, so meaning this could be, this area might be warmer compared to the temperature if you touch them, okay, okay, this can be a sign of an inflammatory response. Remember, there's an elevation in the temperature here, okay, or cooler as compared to adjacent tissues. Okay, so 2 things: cooler, that's circulation problem. If it's warmer, that can be a sign of an inflammatory response. Okay, there is tissue injury. Okay, so color changes do not include purple or maroon discoloration. Okay, so you do not expect to see this purplish or maroon color discoloration on stage 1. That would be your SDTI. All right, because in SDTI, the skin will be intact as well. All right. So blanch response, okay. So blanchable, meaning the skin color returns immediately. And I think I explained this clearly on you guys already. All right. Okay. Non-blanchable erythema, the lack of a blanch response occurs when light pressure is applied or persistent redness in lightly pigmented skin. Okay. And again, these are just some techniques that we can use. Okay. Sometimes I would use a glass slide to do a blanch test so I can see it clearly, okay, if there's indeed a change, but we don't usually use that, okay? So experience will help you learn more of that skill, okay? All right, so now we have a partial skin loss, partial thickness, meaning what again, what level? Partial thickness, what layer of the skin?
2.
What layer of the skin is affected? Partial thickness.
Epidermis.
Epidermis and
dermis.
Dermis, right?
Ew.
So the wound bed is viable, pink or red, moist, and may also present as an intact or ruptured serum-filled blister. Okay, that differentiates from stage 1, intact skin. Stage 2, okay, the blister may have ruptured, caused this kind of resistance. All right. So you won't expect to see a fatty layer in stage 2. Granulation tissue, slough, and eschar are not present in stage 2. These are, again, distinguishing factors. Okay, you do not expect to see any granulation tissue, slough, and eschar on stage 2 pressure ulcer. Okay. All right. This stage should not be used to describe a moisture-associated skin damage, or MASD. Don't worry, I'm not going to test you on this one. Okay. That includes the incontinence-associated dermatitis, intertriginous dermatitis, medical adhesive-related skin injury. This is really very confusing. That's why we always need the expert of our doctors. Okay? These are not pressure-related injuries. Okay? So these are caused by sensitivity to maybe an adhesive like a tape, a prolonged exposure to urine or fecal materials. Okay, so these are what it looked like, very similar to what looked like maybe a stage 1 in some cases. Okay, so we do not. So when we see these types, what do we do? Refer them to the doctor. Okay, so even the doctor themselves would probably call a specialist. Okay, a wound care specialist or a wound specialist to fully evaluate if this is indeed a pressure-related injury or not. All right, but some of them are obvious. Like in this case, this is sensitivity to a tape, perhaps, or an adhesive. Okay, this one is maceration from overexposed to fluids. All right. All right, a viable dermis. So a viable dermis usually should appear shiny red. Okay, you have a visible blood vessel in reticular layer. The edges may be distinct in thick tissue or beveled in thin tissue. Okay, it is painful and may have some serous drainage. Okay. And this is what we talk when epithelialization occurs. Okay, this is what would help. Okay, in the healing process. Okay, so because we are not able to approximate the edges here, we would let the cells grow on it. Okay, but we need to encourage the growth of the granulation tissue, which is in the deeper layers of the wound. This is the granulation tissue right here, and on the top part, that's where the epithelialization would occur. Okay. Now we go to stage 3. Okay, so we went beyond the first 2 layers. We go to the third layer, adipose tissue, the fatty layer. Okay, this is a full thickness loss of the skin in which the adipose or the fat tissue is visible in the ulcer. Okay, in some cases, if it's pretty deep, okay, an epibole or a rolled wound edge can also be seen. All right, that is not a good sign as well. Okay, when epibole starts to set in this patient, that means the doctor may need to do some surgical intervention in this one. Okay, in some cases, you might see slough and eschar on a stage 3, but never on stage 1 and 2. Okay, the depth of the tissue damage varies by the anatomical location again. All right. Stage 3, there is a possibility that there can be tunneling or undermining, meaning there will be openings on the sides of the wound that you might start to have some cavitations there. Okay. You don't expect to see the fascia, the muscle, the tendon, the ligament, the bone in this stage. All right. This is what we call as an undermining, okay, or tunneling. Okay. So it can go even deep to the sides, laterally, okay, diagonally. That's why you want to observe and measure as well when you're doing an assessment on a pressure-related injury, okay? And this is what we don't want to happen, okay? So epibole or a rolled edge, okay? When you look at your assessment on the wound again, let me see if I can make this bigger. Okay, so this is the area of focus, this is the area of problem here, and this is what an epibole would look like. Okay, So on a typical healing process, these are the epithelial cells that are supposed to meet. Okay, so when we say there is re-epithelialization of the cells, they're supposed to meet from both ends, right? This is what in normal re-epithelialization of the, let me see if I can change my color. These are your epithelial cells dividing and growing, okay, during the healing process. If there is no healthy tissue underneath the wound, okay, because it's pretty deep, like in this case right here, right? Granulation tissue is right over here, okay? What would happen to the epithelial cells is it will curl, it would roll, okay? That is what we call as the epiboly, okay? And this is bad. Why? Because now it sends signals to the brain that the wound has healed, okay? That epithelialization has completed, okay? And it will stop growing and the wound will not heal, okay? Because there is the false sense now that the wound has completed reepithelialization. So what does the doctor do? They'll do a surgical procedure. They will cut this, okay? They will cut this to prevent the epiboly from forming, okay? And they would encourage the growth of the granulation tissue here. And then once it reaches there, okay, they can go into the normal process of reepithelialization, meaning they're going to spread across until the wound is closed properly, okay? This is how we close the wound together, okay? So, and again, this is an unexplained, this is how your body is designed, okay? This is how our cells are designed. When both ends of the cells meet each other, okay, they will automatically stop dividing, okay? And we call that as contact inhibition. So contact inhibition meaning when cells start to divide and they meet each other, okay, they will not multiply again. They will stop from replicating or dividing, okay? So that means you can end up with a clean scarring, okay? There are people who would form what we call as keloids, okay? So if this does not occur because of contact inhibition and there is an overgrowth of these cells, okay, the scars become more pronounced and you have people who have developed what we call as keloids, okay? So that's one. So if there's a epiboly, doctors cut it up and then encourage the granulation tissue to grow and then encourage reepithelialization, okay? And it would have a clean healing. All right, this is an example of an eschar and a slough, okay? Very easy to distinguish. Usually it's leathery, hard black or brown, dark brown. That is your eschar, okay? If it's yellowish, okay, it's usually the slough or your dried inflammatory fluids that are moist, stringy, yellow, tan, gray, but typically, again, it looks like an adipose tissue, okay? It looks like some people might mistake it as a pus, okay? It's not a pus, okay? But these are dried inflammatory fluids that are moist, stringy, yellow, tan, gray, green, or brown, okay? On the other hand, the eschar, these are dead tissue, necrotic tissue that is leathery or very thick and hard, okay? And black or brown or tan, okay? Typically, it's black like this, okay? This is how you would see it. So if it's covered by a sloughing or an eschar formation, we call that as an unstageable pressure-related injury. And then we go deeper. Now we start to see the bones, the tendons, the muscles. That's your stage 4, okay? And that's how far it can go. Worst case scenario in a patient, again, you might see this type of injury, okay, where the bones are fully exposed, okay, and that's pretty deep, all right? Now, if this wound right here, pay attention to this, up the right picture, Okay, if becomes covered with slough, what do we call that now? We can stage this, we can measure that, we can see the bony area, we can see the tendons there, okay? But if it becomes covered with slough or eschar, then it becomes unstageable, all right?
Okay.
Okay, this is another example. These are actual photos of someone with sloughing and eschar formation, okay? Then it's difficult to put a stage the wound itself, all right? Another example, unstageable pressure injury, okay? This is covered by eschar or slough?
Both.
Both.
Both. Good job. All right. So you can see both the sloughing and the eschar formation. Okay. And then we have our SDTI. Okay. So that is your distinguishing factor again for an SDTI, a suspected deep tissue injury. Okay. The color, okay, it's still the skin is still intact, but if you look at it closely, if you do an imaging in that one, that's how deep the injury can be. All right. So that's why I said it's pretty scary when I see this on a patient. Okay. Because I would imagine I couldn't imagine how deep the injury might be. All right. It can go far, far, far. All right. So again, these are pictures of it looks benign, right? Especially if you look at the middle picture. Okay. You might say, oh, okay, it can be a stage 1, right? Okay. So be observant on the color. Okay. Be observant on the texture. Okay. So this is now considered as a SDTI or suspected deep tissue pressure injury. Okay. And these are just some examples. And this is what happens when how it evolves, pretty much, right? So even here, okay, you can see that it's pretty deep inside. Okay, just noting the depth of the color of the blood. Okay. So stage 3 or 4, those are full skin thickness injury, pressure ulcer, acquired after admission to the healthcare setting is considered a serious reportable event. That's why you don't want this to happen in you. This is mandatory reporting.
Mm-hmm.
Okay? You need to report this. This is a serious reportable event, and you will get a lot of visit from the state board. I promise you that. All right. In acute care, we assess the patients for pressure ulcers every 24 hours. In long-term care, we assess patients, residents weekly for the first 4 weeks after admission, and then at least monthly or quarterly. Okay. But again, our daily care for the patient is what helps us determine this as well. Okay. So pretty much when we give them shower, we give them bed bath. Okay. We're already doing our skin assessment as well. And this is the reason why sometimes you would have nurses would tell the CNAs, hey, when you go to room 101B, when you're doing the pericare, can you call me please? Okay. And the reason for that, okay, some of these nurses might want to be present to do the assessment themselves as well. Okay, during the time. All right. So how do we assess the patients with dark skin? Dark skin individuals. Okay. So purplish, brownish, bluish. Okay. Look for changes in skin color, such as skin that is darker than the surrounding skin. Okay. You want to use a natural or halogen light source to accurately assess the skin color. Okay. So fluorescent lighting, okay, can cast a blue color. Okay. It makes it difficult to do the assessment. Okay. Assess the area for skin temperature using your hand. The area may feel initially warm, then cooler. Okay. Touch the skin to feel its consistency. Is it boggy or edematous? Okay. So again, you want to feel it as well. Okay. And assess for any signs of discomfort, itching, or pain. Okay. All right. Let's go for this one. Easy question. Feel free to answer it.
Caring for an unconscious patient with a risk of skin impairment, often with the nurse plans to change position of the patient. Isn't it every two? Right.
6, letter C.
Every 2 hours. You move the patient every 2 hours, right?
Letter C.
What is your choice here then, Darcy?
Then
What
it
would
would
you
be
answer?
C.
C, excelente.
C.
Thank you. All right. What about if it's vulture bound? If the patient is vulture bound, what would be your instruction? They should reposition themselves every how many?
Every hour?
15 minutes. Okay?
15.
So 15
okay.
minutes for vulture bound patients.
Okay.
Let's do one more.
15 minutes. The nurse assesses a red blister over the right superior iliac area of a patient. What stage is this decubitus injury? A
Keyword again, keyword. How you would study to remember your important keywords. Blister. Where does that fall?
C.
Okay? So when you study, make your life easy. You don't have to memorize everything. Okay? Pay attention to the important keywords. Good question here. So that means every time we do a wound assessment on a patient, we measure the size, we look at the depth of the wound, okay? We assess for pain, we assess for odor, and the color of the tissue. But collectively, what does this evaluate? Why do we even perform this?
C. I need it.
Final answer? Anybody has a different opinion? Or do you want to agree? Do you want to agree with I heard the letter B? Letter B or D? Darcy said letter C. Anybody has a different opinion in this one? Darcy, why C?
Well, when you're measuring and you're looking to see whether your treatment, every time you assess it, you're looking to see whether the treatment that you're doing is improving it or whether you would need additional interventions.
Excellent response. All right. So the reason for those, when you do the assessment, because you want to know, okay, is there improvement on all the interventions that we've been doing in this patient? Good job. All right. Okay. So that's really the main reason. You want to see whether there is improving or getting worse or getting better. Okay. So when the size of the wound gets smaller, we know that we're seeing some improvement, right? If the cavitation is getting deeper, now we have a problem. All right. So we may start to change or look into our care plan. So again, try to imagine it yourself. From among these choices, which do you think would be most beneficial to the patient to minimize the occurrence of a pressure-related injury? Okay.
Would it be D?
So now you're going to look at the number of bony prominences when someone is lying on their back. You want to see how many bony prominences would be exposed when you are putting someone in a full lateral, okay? Or how many of these bony prominences will be exposed if you put someone on a 30-degree lateral or if they're on full prone, okay? So now you're going to look at the basic anatomy of your body, look at the skeletal system, okay? If I'm doing back, and this is how you would if you're testing yourself, again, you're not sure, okay, this is how you would respond effectively, okay? Go back to what you learned from your A&P, okay, and then start figuring, if I'm lying on my back, okay, which areas on my bony areas would be more prone to pressure exposure, okay? If I'm lying on my side, okay, that's how you would correlate now what you learned from your A&P, okay? But the answer here would be a 30-degree lateral, okay? It's some critical thinking question. Okay, let me call on.
30-degree lateral would be.
I'll show you that. That would be my next topic.
Okay.
That was just like a pre-assessment question. All right, Mary Jane. Mary Jane, are you with us?
Yes.
Okay, let's see if you can try this one, please. You can read the
Mr.
question now.
Critical thinking. Mr. P has a poor appetite and his chemistry profile reveals low protein, low albumin, and a low anion gap ratio. Explain why poor nutrition predisposes the patient to impairment of skin integrity and poor tissue healing.
So, from among the food types that you take in, what do you think would be the most important in terms of wound healing, tissue repair, immune system? Okay, you have your carbs, you have your fats, you have your proteins, you have your nucleic acids as food sources. From those four major categories, what do you think would be most helpful for Mr. P?
Protein.
Protein, very good, right? Okay, so because proteins are important for tissue repair and proper immune system. Okay, but here, okay, explain why poor nutrition predisposes the patient to impairment of skin integrity and poor tissue healing. Why is that? And that's what I want you to think. And you're right on there. Protein is the best source to supplement a patient's healing from wounds or surgical or surgeries.
Maybe Mr. P has a diabetes.
No, but why poor nutrition? Why do we correlate poor nutrition with problems on the skin, okay, or poor tissue healing? Poor appetite, his chemistry profile. I'm not even gonna pay attention to that pretty much, but I'm gonna look at the Mr. P as a poor appetite. Okay, so knowing, okay, can we get protein endogenously? Can our body manufacture our own protein? No, right? Okay, the only source of protein is through your dietary intake. Okay, so whatever we take, okay, our body converts them into human protein. All right, but the only source of protein is through dietary intake. We do not manufacture our own protein. Okay, we can synthesize the proteins that we take in from the food that we take from the food that we ate through the liver, but we don't manufacture our own protein. So if the patient has poor appetite, okay, that can put a lot of impact in their skin integrity and their healing. Okay, so typically again, just remember protein is important because it plays an important role in the immune system and tissue repair, and you cannot make your own protein. Okay, we can synthesize the proteins that we take as food, okay, but we don't manufacture our own protein. All right. Intervention again, nursing intervention of patients with pressure injuries include ongoing assessment. Okay, we've gone through that, size and depth of the injury, presence of any undermining, the amount and the color of any exudate, the presence of pain or odor, which is already an integral part of your assessment, and the appearance of the exposed tissue. Okay, for pressure-related injury, healing is a long-term process. Okay, so make sure you have a good care plan for this patient that is consistent. Okay, and always maintain and continue evaluating your patient as you go along. Okay. All right, let's have some volunteer here. Who wants to read this, please, for me? Go for it. Thank you.
Pressure in. Are you able to hear me?
Yep, go for it. Arnold.
Pressure injuries. General guidelines for care of pressure injuries, box 9.5. Never massage reddened areas. Risk of further skin breakdown. Massage over bony prominences is no longer recommended. Massage results in decreased blood flow and tissue damage in some patients.
Okay, so 2 areas. Reddened area, bony prominences. We don't encourage you to do massages in those areas. Okay. Number 2, go for it, Arnold.
Nutritional support, which promotes healthy tissue repair, is likely to be as important as local wound care for the patient.
All right. If the patient is not properly provided with a good nutrition, okay, that can also affect how the wounds would heal. Okay, and in this case, we know that protein is also important.
Excuse me? Oh,
Yep.
I'm sorry. Is it okay if we take a break?
Sure. 2:20. Let's go back. Let's do a 10-minute break, please. 2:30.
Thanks, Danielle.